final 10 seconds for this kickoff of the second Inter-Country Peer Learning Exchange. This time we are honoring two countries in particular, but welcome participation from all countries. So the first country is Nigeria. Here you see a picture from Nigeria, and then also from Uganda. These two photos are from a collection of photos shared by immunization practitioners during World Immunization Week. So we want to honor Omolara Adeyemi, who's here seen in the Makoko Riverine community, and then also Namalwa Mili from Uganda for today's event. We'll be, as I said, diving right in and focusing on two topics, deep diving into integration, maximizing opportunities to reach zero-dose children and missed communities, and then topic two on microplanning, planning, implementing, revising as a continuous process. Just before we kick off with the first story, again, back in July, we started, there were 22 people registered for ZDLH-X2, and today, very pleased to announce that there are, as of this morning, these numbers have probably shot up some more, 2,203 immunization professionals registered. Now, 2,203 this morning, and you can see here the participation by country, including the 4 countries in red. But today, for the very first time, we're going to double click into each country and look at the specific target districts, areas, local government areas that the Zero-Dose Learning Hub project supported by Gavi is going to be specifically looking at. Most of you are directly involved in zero-dose work, and you can see that there's a healthy representation. The majority of you are from districts, regions, or states, and the facility level as well. Now we want to honor country learning hubs supported by Gavi in Uganda and Nigeria that are part of this Zero-Dose Learning Hub exchange today, as well as colleagues from Mali and Bangladesh country learning hubs. We, of course, before we start, wish to acknowledge Dr. Faisal Shuaib, Dr. Basil Posen from Nigeria, and Dr. Henry Mwebesa and Dr. Michael Baganazi from Uganda. Now, before we hear the first story, the first experience and case study that we're going to discuss, we also want to honor today 154 of the practitioners from Nigeria and 25 from Uganda who are working in the focus districts for the Gavi country learning hubs, where formal research and other activities will be carried out in the coming months and years in order to support zero-dose in work. So we especially want to thank and recognize those 25 participants from Uganda country learning hubs, as well as 154 participants from a number of Nigeria country learning hubs, local government areas that are receiving dedicated support and being part of this country learning hub in Nigeria and Uganda. You can see their names here. And again, they took the time out of their busy schedule to actually share their experiences. So we're now going to jump to the first case. Charlotte, I hope you are ready, and we'll be looking at this first topic of integration. I believe Scovia Okello will be our first speaker. Over to you.
Thank you, Reda. So I'm really delighted to introduce Scovia Okello, that is a midwife working at a health facility in Kotido district in Uganda. Her challenge is reaching zero-dose children born at home by mothers who attended antenatal care by tracking their expected. The intervention consists of documenting the expected delivery date of the pregnant woman, and if she fails to show up 1 month after that date, the assumption is that she must have put to bed somewhere else. So village health teams and community leaders are engaged to locate the mother and determine the vaccination status of the child and ensure that the child receives the required vaccine doses during vaccination sessions. So I am glad that Scovia is with us today, and she has already unmuted herself. So welcome to you, Scovia. Please, can you go ahead and maybe add some more to your introduction, who you are, where you work, what you do?
Thank you very much. Thank you, everyone. I'm Scovia Okello from Kotido, Karamoja in Uganda. I am a midwife. I work in the Lower Health Center 3 in Kotido district. I'm very happy to be here today. My experience is on integration, and in that we are using antenatal data to follow up on birth and vaccination. So going straight to my story, what we decided to do as a team handling immunization and antenatal, we sat down to review our data, and in our data we saw that mothers are coming for antenatal and they get lost on the way, they deliver and they don't come back for immunization, and some children missed their immunization doses. So we sat as a group, we said, what can we do to help capture these children? So we planned, like when a mother comes for immunization, for antenatal the first time, we track this mother, we follow her up. Like if, for example, today a mother has come for antenatal, she is 5 months pregnant. So we saw, like, let's calculate the expected dates of delivery or month of delivery. But the challenge is most of our mothers, they are not sure, or they really don't know their last normal menstrual period. But what we do our examination, we take history from a mother, like today I've come for antenatal, I'm 5 months pregnant. So when we palpate, we get like she's like 20 weeks pregnant. So we had like 4 months to today that she has come. So we expect this mother to deliver like maybe in January, because she has reported when she's 5 months. So we are adding 4 months to make 9 months. So we expect this mother to deliver in January. So we keep on following this mother. In case this mother fails to show up in January, which is her expected month of delivery, we expect that maybe she has delivered from somewhere, either from home or from another health facility. So this is now where we involve the village health team members or the community members, whichever the mother is comfortable with. We involve them to help us follow up on this mother to find out if at all this mother has delivered from home. We encourage this village health team member to bring this mother for immunization, either in static or in outreach. So that is what we do to track up this mother using our expected month of delivery.
Thank you very much, Scovia, for sharing that. I have a couple of questions for you. My first question is, do you know how many of your zero-dose children come from mothers who have attended at least one ANC before? Can you estimate that?
Roughly, I can estimate like there are 40, because we started this project in April this year, and we are giving it a period of 6 months so that we review if it is working. So we have seen that it's working. We have roughly like 40 mothers who came for the first ANC. They got lost. We tracked them up. They came back to the program of immunization.
Okay, and the next question is, are there other health facilities in your district that have adopted this approach to identify and reach zero-dose children?
Okay, thank you. Like we started it as a facility, a single facility in the district, and we are like, let's first try from us. When we see that it is working, we can now involve in some other health facility. At the moment, we still don't have another facility practicing, but you are like, if we are to start by October to also involve in other facilities, we have some challenges that we will look upon other NGOs or other partners that can support us, so that we also do the mentorship to other health facilities so that they can also pop up the same on whatever thing that we are doing in our facility. But at the moment, we have not yet involved other facilities in it. Thank you.
Okay, thank you, Scovia. Before I hand over to Reda and our guides on the side, there's a question in the Q&A from Shadia Mugizi Natenza that wants to find out, how do you track mothers who don't come for ANC?
Okay, thank you so much for that question on tracking mothers who don't come. Most times we use these village health team members. We always have meetings with them to map out all pregnant mothers in their areas. So we really rely so much on them. They are the people who connect us to these mothers because they do their mapping every month and they send to us the report. So we rely on them and they help us track these mothers. Then secondly, in our district, we have NGOs or partners who always give protective ratios like food ratios to pregnant mothers, to breastfeeding mothers, to malnourished children. So we use really that opportunity also to track up these mothers, because in that distribution point, when a pregnant mother has no antenatal card, or a mother has no child health card for the child, that mother is not worked on. So what they do, when you go there, the first thing for you to present is either antenatal card if you're pregnant, or a child health card if you are a breastfeeding mother. So in that point, most mothers come, in our region, there's a hunger. So when there's something like food ratios given to such category of people, they really tend to go there, and that is where we really also go and capture those mothers from. Thank you.
Okay, thank you so much, Scovia Okelo, for sharing your intervention with us. Reda, I think it's time for us now to introduce our guides on the side.
Indeed, and one message is, I am seeing people introduce themselves. That's wonderful. But as you've been listening to your colleagues, we'd like to ask you to think about these questions. When you listen to a colleague, how different is this from the zero-dose challenge that you face? And then in the chat, you can tell us about this challenge. What is different for you? That is what we'd like you to share in the chat. And also, if you feel that you have something you can contribute in response to Scovia Okello's experience, then you should certainly raise your hand and let us know that you would like to speak. Now, you can see on your screen, so if you're on your phone, look down and you'll see that we are joined today by 4 guides on the side. Now, the first is Boma Otobo, who's a former deputy program manager at NERIC. A warm welcome to you. Dr. Rita Tuganza, deputy program manager at the Uganda Ministry of Health. And then we have Jenny Sequeira and Dr. François Gass, who are senior immunization advisors advising the Zero-Dose Learning Hub. Now, what is a guide on the side? Well, it's really the one way to think about it is if you are sitting down, Jenny or François or Boma or Rita, side by side with Scovia Okello, who just shared and described the practices and the challenges that she faced in her health facility in Kotido district, what would you tell her? What questions would you ask? How would you actually provide guidance or provide support that would be helpful to her? That is what a guide on the side should be, and that is what we're asking Boma, Rita, Jenny, and François to do today. Back to you, Charlotte.
Thank you very much, Reda. So I'll first of all like to turn to Boma Otobo. Boma, I hope you're able to unmute. You have listened to Scovia's intervention, her story. Do you have any comments, and what questions, follow-up questions, do you have for her?
Okay, hello everyone, and I would like to congratulate the organizers for this ZDLH-X 2. Having attended the first one, I know this one was so important to also follow up on and see what is going to be different from what we've done in the past. And so I'm glad to be one of the guides on the side. And to Scovia Okello, I would want to congratulate you for articulating this problem as best as you could. Integration has always been the way to go globally, because we know We have shortage of staff, personnel that can actually carry out all the activities. So when we have opportunity to integrate, that's a very good one. Now, your story about using ANC data to follow up on births and vaccination, that's a good one. One thing I've seen in your story, the mothers are coming for ANC, but subsequently children are not being brought for immunization. I would have loved to ask you, what is the utilization rate at that facility? Is there a challenge when people come to access immunization? And another question would also be the dropout rate. How is it in relation to other facilities that are around? So when you begin to dig deeper, doing a root cause analysis, more or less, to find out why this is happening, then you'll be able to come up with solutions that are targeted at that specific problem. And one of the advices I would like to give to you is to request the communication group in that particular facility to have key messages to target these mothers. When they come for health talk, what messages are they passing on? Are they advising the mothers to come back and continue the immunization of their children? And then the second advice I would like to give to you, we know that the fathers are a very key stakeholder in immunization. What are we speaking to the fathers about? So what do we need to bring them together in a dialogue or something like that, and ensure that we also pass on the same messages to the fathers to ensure that immunization continues for their children and not just to move elsewhere? And so those are the two things I would like to bring to your knowledge today. And I want to say kudos to the team from Uganda. This is a very well thought out story, and I'm glad to be one of the guides on the site. Thank you. Over from me.
Thank you very much, Boma. And I see Kovia, you're already unmuted, so you can go ahead to answer the question.
Thank you very much for listening, and thank you for the question. So the first question was like, why is it that mothers are coming and they drop out on their way? So the community where we stay in, sometimes it is a mobile community, and there is also insecurity issues, and there is also issues of hunger. So you get that there are periods where these mothers move out of their homes to the settlement camps. So like in rainy season, especially, these mothers go out to look for pasture and to look for really green belts where they can plant and get something. That is the time where we always experience this dropout of these mothers, and also insecurity issues, where sometimes some roads are blocked. A mother may not be in position to come to the health facility or the health service delivery point, and also sometimes distance from where the health facility is, where a mother is supposed to cover approximately like 12 kilometers or 15 kilometers to the health facility. So it becomes too much a challenge to these mothers, so they end up like dropping or even delivering at home because of these insecurity issues, especially night time. When labor starts at that time, it becomes so hard for them to report really to the health facilities, so they end up sometimes delivering from home. That is the challenge that we really face, and I think it is the reason why we really drop out some of these mothers on the course of the pregnancy. And then in the drop rate, we sat as a team in the health facility, because first we had a district meeting where all health facilities are invited for the review meeting on their specific targets, so indicators, and from there we saw that there is a drop rate in immunization. So the representative who went there brought out the feedback there is dropout in this immunization. So what do we do as a team? We sat down and we started reviewing our data, where we suggested, like, let's have a weekly review of our data and we see where are we going. Are we on the right track or we are not on the right track? So we sat down to review this immunization data. We saw that we are not performing quite well, and we came up with this plan of tracking these mothers during pregnancy up to the time of delivery and immunization. Thank you.
Thank you so much, Scovia. I would like to turn to another guide on the side, Jenny Sequeira. Jenny, warm welcome and over to you.
Thank you, Charlotte. Thank you, Scovia. And it's great to see so many familiar names from Nigeria and Uganda. Thank you for joining the session. So Scovia, there's a lot of questions in the Q&A about the role of traditional leaders, religious leaders, aside from the village health teams. Can you talk a little bit about how you use these traditional leaders or religious leaders or other key community leaders in how you address and are able to identify some of your zero-dose children, including those born from the mothers who birth at home? Thank you, Scovia.
Over to you, Scovia.
Thank you so much. Thank you for the question on the community leaders and religious leaders. So we also involve them, but not all that much like these other village health team members. These community leaders, especially the area councillors, we always, when we have community dialogue, we involve them in the mobilization, and then we go deep in the community. We give health education on the benefits of this attending of immunization and antenatal. So these people help us in mobilization, and they also help us to talk to these mothers deep in the community. Because in my community, my people really are still too much in their community, the people they stay with. So when we involve them to help us talk to these mothers on the benefits of this immunization and antenatal, they really support us a lot. They also refer. Sometimes they refer, sometimes they just come with the mother up to the health service delivery point. Thank you.
Thank you so much for sharing your zero-dose intervention, Scovia Okello, that is focusing on tracking expected delivery dates of pregnant women through antenatal care data. So, Reda, I see lots of comments in the chat and the Q&A.
Yes,
so
indeed.
We could identify one or two persons in the room who have maybe a comment around this intervention or question for Scovia.
Yeah, so do write your comments in the chat, and if I'm going to lower all of the hands right now, why? So that if you actually have something that you feel is really going to contribute to help Scovia Okello with the challenges that she's facing and potentially help your other colleagues, if and only then and only if should you raise your hand. And then, of course, a reminder about the rules of engagement. We try to find a balance between the different countries, and of course between men and women. So, Charlotte, I suggest George Ekwaro was the first to raise his hand. I suggest we go to George and see what. Hear from George directly. I'm also going to go to Giselle Kazadi. And maybe we'll go to her next. We have 7 minutes left to go on this in this first half of ZDLH-X 2. George Ekwaro, a warm welcome to you. Do introduce yourself. Tell us who you are and what you do, and tell us what you can share. What is the experience, the thoughts, the reflections, the practice that you'd like to share with Scovia Okello that you believe can actually help her with the zero-dose challenges that she faces. George?
Yes, thank you, Chair. My name is George Ekwaro. I work for UNICEF as a Red consultant in charge of 18 districts and Moroto Zonal Office. UNICEF zonal office. My experience in Karamoja, as Scovey has already put forward, I just subscribe to it. But then I would like to add some other areas that need to be improved. For example, I've realized that there is a lot of data that has been generated at facilities and have not been entered into the DHIS too. And I'm encouraging health workers in that area, especially the managers at the level of DHOs, ADHO, MCH, and biostatisticians to make sure that those data are entered into the system so that we are able to know the number of actual zero doses in the community. The issue of community mobilization using the non-health stakeholders like political, religious, cultural leaders are going to be intensified, especially in October this year when we are implementing the Integrated Child Days Plus. Here in Uganda, we implement it in October and April of every year. We are also going to involve schools so that they can help us reach the children who require those antigens, for example, HPV, deworming tablets, and then vitamin A supplementation among school children. So we think that if it's implemented well, we shall reduce on the number of zero dose cases and then the under-immunized. We are also planning to introduce child registration, which will help us to track children who have missed to be immunized or those who have been under-immunized. The child registration will be implemented by the village health team, and they will be using those registration details to follow up children who will have not been vaccinated and then mobilize them to bring them to health facilities or in outreaches to be vaccinated. We also supporting districts to intensify operation of static and outreach facilities so that we are able to reach these children, especially in difficult areas. Of course, there are in areas like Karamoja, there are certain areas which are very difficult to access due to many reasons, including insecurity, which sometimes actually hinder access to health facilities. And then there are also issues where sometimes health workers get challenges, they can't move to outreaches, especially where there is insecurity. So we are trying to work with districts to make sure they step up their activities. And we are hopeful that maybe before the end of this year, something is going to change, maybe around November there when we do analysis. The number of zero dose cases and under-immunized children is going to reduce significantly if what we have in plan is implemented as it is at the moment. Thank you, and over to you, Chair.
Thank you very much, George Ekwalo. Right now, to we turn to Giselle Kasadi.
Yes, indeed, Giselle. I'm trying to unmute you. There is also, let's see, there is also Michael Jones and others with raised hands. Of course, we're not going to be able to get to anyone. Please be concise, get to the point, focus, try not to repeat yourself, and really think, is what I'm saying, is it actually useful to Sokia Okello? That is what the sharing of experience is about. Giselle is not answering despite the hand raise, so may not understand how to unmute in order to speak. So Charlotte, let's keep moving. Who shall we hear from next? We're almost at the halfway mark where we'll mark a pause to honor the ZDLH-X 2 contributors, and then we'll go on to the second case study. How would you like to use the final 2 minutes? Let's see.
I'm inviting Michael Jones to unmute Reda.
Yeah.
If not, we also have Ahmed Yazid.
All right, so we'll hear one last speaker, knowing that you have less than 2 minutes to speak. Also asking them to... All right, Michael, a warm welcome to you. I see your mic is unmuted. Please introduce yourself. Tell us who you are, what you do, where you're from, and tell us what are you bringing to the table that can help Sokia Okello with the challenges and the work that she's facing. All right.
So, good day and good afternoon and good morning wherever you are. So I'm Michael Jones, and so I work with the Childhood API program, provide technical support to the Childhood API program on immunization, and then much more focused on new vaccine introduction and routine immunization, and then we will help to continue developing strategies towards and then integration and then zero-dose identification, the EAF, and all the application towards we sent to Gavi have provided technical support towards this. So quick one from my own take and recommendation, and for us what we've done so far here is how we integrate and then our activities and then towards and zero-dose identification. So we engage our facility health staff, and then in terms of doing and then integrated outreach to hard-to-reach areas. So firstly, identify the hard-to-reach areas and communities, and of course, we engage them to conduct integrated outreach services to these hard-to-reach areas. And then extra resources are provided towards this. And of course, for the stakeholder, we engage them to be fully involved in the whole process. So whenever we develop and then whatever intervention or strategies, we have the traditional healers and then the local authorities, I mean the paramount chief, the section chiefs, they are all involved both at district, national district, and at chiefdom level, and they give their own input and contribute towards this. And this gives sense of ownership towards this, and we're able to see how they can take this and able to. Additional part is that also, because we involve them, they are also involved in developing what we call bylaws for the community, which tells the community people that, hey, if you are default in XYZ of not getting your child being vaccinated, then of course you are fined, you are liable to pay a fine, and there are consequences. And also, apart from that, they will also provide and then orientation for their community people about the essence and the importance of vaccination. So the community stakeholders are part of the whole process, and they provide so much support in also redesigning our strategies and then implementing our programs. So this is one thing I think I would like to bring in, that the importance of community stakeholders, and of course integration process with other primary healthcare services, which is very important and effective. And then of course we also have to bring in the private hospitals, because there are also private hospitals which we believe they are very important and providing immunization services. But then these have not been fully involved, and in most cases we think
Michael,
that they are at the point where they can able to,
thank you.
to reach out to those kids. So
yeah, please conclude.
Involved. So that's all I have to say to them. Thanks.
Thank you very much, Michael Jones. Again, the emphasis is not on generalities, but what have you done to include private facilities, for example? That is what we're most interested in this inter-country sharing of experience. Now, we've been looking at integration opportunities. We're about to go into the second half, but I believe it is likely that there will be overtime, given the level of enthusiasm, given the amazing numbers in the room, and the amazing numbers registered for today's event. And so we are now going to mark a brief pause to honor the practitioners with a focus on the two focus countries. Now, first of all, we want to honor all of the contributors who shared their zero-dose experience ahead of the event, and we want to zoom in on the Uganda contributors. 63 of them shared their zero-dose experience. They did not have to do this, and if you did it because you wanted to. You chose to contribute to the shared learning of your colleagues, of the country partners, of the country learning hubs, and of Gavi, the Vaccine Alliance as well. Now for Nigeria, we have an amazing number, 379 contributors. So busy practitioners who took time out of their busy schedule in order to share. It'll take a little bit longer to go through the list, but take a moment to appreciate your colleagues who are really sharing because they want to, and sharing that zero-dose experience. This is just a list, the same list with the headline in French. We also, along the way, want to give a nod to the TGLF ambassadors from Nigeria who worked very hard to actually disseminate, to really spread the word about this event on behalf, really for their fellow practitioners, not for the Geneva Learning Foundation, not for Gavi, but because they believe in the value of this peer learning for their colleagues and wanted to make sure that we would this event would be shared. We also have ambassadors from Mali and Bangladesh from all 4 of the country learning hubs. We also wish to recognize our guides on the side. I hope that they're ready to sort of pull back, zoom out, and tell us what have they heard so far. There are right now 28 questions open in the Q&A. There have been many high quality contributions and shared in the chat itself. It's difficult to keep up, we'll be looking to our guides on the side to pull it all together and give us the big picture. Now, back to you, Charlotte, for what I believe is the second case study. It is Abubakar Mohammed Amali. Unless I am mistaken, you will correct me.
No, rather you're not mistaken. It's definitely Abubakar Mohammed Amali, who is from the district level in what is known in Nigeria as the local government area level in Sokoto State. So his challenge is, their challenge is to reduce missed opportunities for vaccination for zero-dose children who visit health facilities for other primary healthcare services. The intervention that they put in place is the missed opportunity and service integration strategy, which entails screening and registration of clients for multiple services, including vaccination at the front desk of the health facility, delivery of a referral slip to the client, including additional services, guiding the clients, guidance of the clients by health workers to the various services based on the referral slip, and the early data. And doing all of these, early data indicates that better routine immunization rates have been recorded with the most in their large health facilities. So Abubakar Mohammed Amali is with us today and definitely has more to share about this intervention. And I see he's already unmuted. Abubakar, I would like you to introduce yourself, and I will ask you a few questions before turning over to our guides on the side. Over to you, Abubakar, for your introductions.
Thank you very much. Thank you very much, colleagues. I'm glad to be here, and I appreciate all the contributions so far. And I am Abubakar Mohammed Amali. I'm a pharmacist with PhD, currently working with World Health Organization at Sokoto State in Nigeria as Assistant Public Health Officer, and also as routine immunization focal person for the State Field Office in Sokoto here.
Okay, so my first question for you is, do you have any evidence on the number of missed opportunities for reaching zero dose and under-immunized children where you work? If yes, what are they?
Yes, we have evidence because, first of all, I want to inform you that this missed opportunity service integration strategy is currently at its pilot scale in Sokoto. We are looking towards seeing how we can scale up the strategy to all the affected LGAs. We have 13 zero-dose recognized LGAs out of the 23 local government areas in Sokoto State. So as it is, we have started with one metropolitan LGA where we have a lot of missed children due to so many factors. So it's currently ongoing, and we usually collect data on a monthly basis. We have separate data tools that we do give to the service providers where this data is being collected on a monthly basis. And we have evidence to show that really we are getting it right, and we hope to scale the strategy up. When we get the support from various organizations. So currently we have data to back up our improvement in RI performance from the missed opportunity service integration strategy. I think as at August, the last data we collected in August, in one health facility, we have up to 161 children, zero-dose children that were able to reach from this integration, from this strategy.
Thank you, Abubakar.
Yes.
Is the absence of documented evidence, like maybe caregivers coming with children without immunization cards or booklets,
Pardon, sorry, the network is not...
hospital, a problem?
Please come across. Come again.
Okay, my question is the absence of documented evidence, like immunization cards or booklets at the time of the visit to the health facility or hospital, an issue?
Now, for now, it is not really an issue because we have enough data tools that are being pushed to the health facilities. Usually, we supply them on a monthly basis. They don't have to come to collect it. We have a monitoring and evaluation unit that are in charge of distribution of data tools, including the immunization card. So for now, it has not been an issue for us.
Okay, so if a caregiver comes to the health facility for the first time with a child, and the child does not have any, and the mother says maybe she forgot the immunization record at home, how do you determine the status of that child?
Yeah, usually we register children by settlements. So if the child is already, enrolled into immunization, since we do our registration by settlements, even if the card is not there, we'll be able to, trace from the RI register. And if it's a zero-dose child, we instantly register the child to commence his immunization. But usually we do registration by settlements, and we have volunteers that usually knows the children that are found in those settlements. So tracing the child's record is not really a big issue because each health facility register the children by their settlement. So as soon as we go into his settlement records, we will be able to track, we will be able to identify the child.
Okay, thank you so much, Abubakar. Have you thought about adding the tetanus vaccination component for for women of childbearing age into this MOSIT approach?
Yeah, this MOSIT approach covers, other PHC services, including RI, malaria, the CMAM, and other services. So since ANC is already captured in the strategy, where the tetanus vaccine is also included. So we also have records for other services apart from the routine immunization. We do collect data of other services that have been integrated.
Okay, thank you so much, Bakam Amali. I want to turn to Jenny Sequeira, who has been listening to you attentively and also throwing an eye on the question and answer function here in Zoom. Jenny, any comments and follow-up questions for Abubakar?
Thank you, Charlotte, and thank you, Abubakar. I think the MOSIT that you describe in Sokoto is also done in Kano with missed opportunities and in many other places. And it's great to hear how you're implementing it at the hospital level. I wanted to know, when you started this intervention, what was the approach for making sure that the children who are vaccinated, their records are then known by the health facility of their origin? So, for example, that child who comes and gets vaccinated may be from another LGA or a town that's in a different catchment area. How does the health worker in that area know that the child has been vaccinated here if the child never goes back to its health facility in the catchment area where it originated from?
Yeah, usually when we get children who are not from that catchment area, we don't allow them to go unimmunized. We try to immunize them and also, properly guide them and counsel them because of if it involves distance, we try to show them the advantage of stand at the proximity side, and we also try to inform them that the same services are being rendered by health workers, and it's easier for them to access those services in their catchment area because of transportation and other logistics problems. And we then we usually have a communication between and also we do a kind of monthly review meeting where we validate all data. All the service providers in that LGA will come together and validate data. So if there's any data for another health facility, that validation time, we do communicate and we do assign those records to the health facility concerned, so that when the child arrives at the health facility, his data has already been captured. So we usually do reconciliation meetings where we take care of some of these challenges.
Great, thank you. Charlotte, back to you.
Thank you so much, Jenny, and thanks to you too, Abubakar Amali. And based on the comments in the chat and questions in the Q&A, there's a lot of interest in the intervention that you're carrying out and in the story you have just shared. So Reda, is it time for us to maybe take one or two questions or comments from attendees in the room before we move forward?
That's a good idea, Charlotte. I see two hands raised. One is from Auta Samelia and the other is from Abubakar Musa. Let's go to Auta Samelia. Keeping in mind our rules of engagement, so if we have heard, we would like to hear from different countries in a balanced way, and we would like to hear from men as much as we hear from women. So if you are a woman who is from a country that we have not heard from yet, I would like, and especially also if you are francophone, and this is getting you to think, and you have something that you feel could help Abubakar Mohamed Amali, please do raise your hand. So let's go to Auto Samela, and let's see what Auta, you will correct the pronunciation of your name, will tell us. I'm asking you to unmute, and anyone else, please do raise your hands. There's an incredible number of great comments in the chat. Auta Samela, yes, please do introduce yourself. Tell us who you are and where you're from, and what are you bringing to the table with your experience that you believe can actually help Abubakar Mohamed Amali with these with his zero-dose challenges in his LGA in Sokoto State. But first, introduce yourself.
Hello, everyone.
All right, Abubakar Musa will come to you next. Let's go to Auta Samela. I'm just asking you to. Okay. Yes, please go ahead. All right, and we may have just lost everyone. All right, let's go to Auta Samela again. Microphone was unmuted, and then we also have Isa Adamu. Yes, Abubakar Musa, the floor is yours. Introduce yourself and tell us what experience, in your experience, things you've actually done or carried out can be helpful to Abubakar Mohamed Amali.
Okay, good afternoon, everyone. My name is Abubakar Musa, and I'm from Nigeria, reside in Bauchi State, and I'm working under facility level. Before, in our LGA, that is Shira LGA, we are among the 13 LGAs in Bauchi State that are under that has zero dose, which our LGA teams been invited to Kaduna and address the issues. We really appreciate on the strategies they make in order to address the issue of zero dose in our LGA. Before now, there is an organization called New Incentive. They really give us more in order to boost our immunization coverage across the LGA. Before now, caregivers or some children may not come for immunization, but due to the incentive of 1,000 that organization New Incentive given to that caregivers, so now the caregivers are coming from very, very far place in order to receive their vaccination. So for now, we are really, really happy for the organization that is All Babies Are Equal. We are really happy with it because it always helps us to boost our immunization coverage here in Shira local government, entirely in Bauchi State at all. So apart from that, due to the lack of permanent health personnel in our local government, also the issues is some of the RI service providers are volunteering. So they just decide to come anytime that they wish to come, not anytime, not at all. In the sense that, like now, for instance, if the facility have session today, if that RI service provider, because he is just volunteering and he's coming from very far place, he have no money to fueling his bike and coming for that clinic or let's say facility, so he will not come. So due to that issues, we are always try to convince the government in order to engage them into the system so that the thing will go in smoothly.
Thank you, Abubakar Musa. Let's go now to Auta Samela. Auta, I'm glad you figured out how to unmute your microphone. Do introduce yourself. I hope it's working now. And tell us...
Yes, I'm Auta Samela.
Yes, and please be very
Nigeria.
Specific. Auta, please be very specific and tell us what you've actually done. Not only that you have this or that opinion. Thank you.
All right. Once more again, good afternoon to you all. I'm Auta Samela from Kaduna State, Nigerian, Jama Local Government, a divisional secretary with the Nigerian Red Cross Society, with almost 300 volunteers under me. What we did here in Jama Local Government for the zero dose, like most especially in the rural area where the healthcare givers cannot actually reach, what we usually do is to kind of have a review meeting with the Jama Local Government Health Facility. We try on our own aspect to make use of our motorcycle, carrying most especially the health caregiver, taking them to the rural community where they cannot reach in helping immunizing all these children. And also, all those the physically challenged, we also make sure that we try to convert them in a particular location, whereby the caregivers now health facility will come and meet them in a specific location and give them the vaccine. We not take them back home. I think with this strategy, it has helped a lot in my local government here with my volunteers to make sure that we reach all those places where the caregiver cannot reach.
Thank you very much indeed, Auta Samela. Let's go back now to Charlotte. Shall we hear from the guides on the side to sort of pull out and give us some insights from what we've been listening to, or should we go to another another zero-dose practitioner to hear the experiences that they would like to share? It's up to you.
Thank you so much, Reda. I would like us to turn to our guides on the side. I think we'll be wrapping up on the integration, how to use integration of primary healthcare services to identify and reach zero-dose children. And I would like to invite our guides to summarize their key takeaways from the two interventions that we heard this morning, as well as all of the comments and the questions that they have been seeing. So I am going to start with Boma. We'll start with Boma and then Jenny, and then we'll listen to Dr. Francois, guys. Boma.
All right. Thank you so much again. And I'm glad to be here. I would like to share some comments on the second presentation before I summarize. For Abubakar Mohammed Amali, it's a good one you're doing, trying to see that the missed opportunities for vaccination are addressed in that Sokoto LGA. My question will be, you say it's a pilot, and I want to find out how many LGAs is this intervention going on. That's one. And then secondly, the importance of gathering data for decision making is to ensure that problems are being solved. I can see a lot of data has been gathered, But how far have you been able to utilize the data that you've gathered? For instance, you said 163 children were missed in a particular month. Is there a meeting? Sorry? Okay, is there a meeting point where the units are integrating with the RI unit, for instance, because that's where to solve the problem, right? So are there other services that are meeting with the RI unit such that there has to be a decision taken as to what next to do when you see a child has come to access a treatment, a service that is not immunization related? And lastly, I would also want to advise that they should have a point, a meeting point, where every child that comes would first of all go for immunization before coming to access that particular treatment that brought them, because mothers are always in a hurry anyway. So I'm asking them to go for, I'm using malaria as an example. It's a very major disease that affects children. If you ask them to go for the treatment, chances are that they may not come back for the immunization. So is it possible to refer them to go for immunization first if they have missed, and then now bring them to the unit where they can access the service? So just to summarize, like has been said, I'm happy to see that the strategies to use for the zero dose are being implemented by both presenters so far, and we've been able to identify the problems, we've been able to reach our targets, and we're monitoring as well, and we're also measuring. But advocacy is something that I can see we've not really quite done very well on. So I would like us to also explore that opportunity so that we don't just end in problems, and we're not solving the problems. The important thing is to ensure that whatever problems we have identified, we would also ensure that there's an impact in the solutions that we prefer. I would like to stop here. Thank you.
Thank you very much, Boma. Otobo, Boma asked you a number of questions. Abubakar Mali, I would like to invite you maybe just to respond in the chat, while I will crave the indulgence of Jenny Sequeira and go directly to Dr. Francois Gaz so that we can hear his comments and the key takeaways from this first topic. And by the top of the hour, we'll move on to the second topic on microplanning. Over to you, Francois.
With just a few minutes left in this sequence, so everyone will have to be concise. Thank you. Actually, so don't see Francois in the panel. Okay, so he's somehow dropped out of the panel. No big deal. Let's bring you back in, Francois. You'll have to accept the invitation, and in the meantime, let me just say for everyone, as you're listening, I'm really, really impressed by the quality of the comments being shared in the chat, by the many questions. And do not be frustrated if you do not feel like we're recognizing or answering everything that you're asking right now. The ZDLH-X process is a learning process over time. We'll be saying a little bit more about that at the end. It is not a one-off event. Back to you, Charlotte, and I hope we have Francois.
I am here. Yeah,
okay, wonderful.
First, I would like to really thank the two presenters, because I think they address a strategy that seems to make a lot of sense to me. And I was particularly interested in using the pregnant mothers to detect the children to be born, and that will be followed by the vaccination, the first one, second one, third one. I think if we could detect all pregnant women in the world and expected that and follow-up, we would be doing very well with zero dose. And one thing I maybe have been missing is the size of the problem in people who are presenting. You know, you're focusing on solutions. And I was wondering very often, what's the size of your problem? And is your strategy the one that will correct 50% of the problem or 20% of the problem, even if it's a good one? Because every strategy has a consequence. You need to focus, you need to invest time, people, money, often, and you expect to make the best impact possible, as was mentioned by the guide. The impact is extremely important. Now, for the missed opportunity, the missed opportunity approach and strategy, you do it in hospital, but I was unclear on, be clear what the benefit. How do you measure the benefits? Because do you see more Penta-1 administered since you introduced your pilot study? But as it was also mentioned, I want to again put the hammer on the nail. Monitoring the impact of your strategy is extremely important. I was wondering, when a child comes to the hospital and is called a zero dose, maybe he would have come anyway, but he's zero dose at the time of contact. The problem is, are you catching up those zero dose that don't come to the hospital at all? So what's a really potential benefit of missed opportunities? However, I think catching the under-immunized, the defaulter, in the hospital must be a very big impact, which will be worth also monitoring. So thank you for your presentation. And I hope that we need a bit more of the target you try to achieve, how many zero dose you try to target, and what you expect from the strategy you put in place. And did you have some evidence that it would work? Thank you again. Bye.
Thank you very much, François Gas, Jenny Sequeira, Boma Otobo. Dr. Rita Tugonza is on her way. We're still hoping that she'll be able to join. She had a conflict, but we are here together for this second zero-dose inter-country peer learning exchange. Uganda and Nigeria are the two countries being honored today, but all countries are invited to join, to contribute. A good experience, a good idea can come from anywhere, can come from everywhere. Also a reminder that in today's session, we're really focusing on a number of local government areas in Nigeria and districts in Uganda, where the Gavi country learning hubs will be carrying out research and other activities. So if you are from Bauchi and Ganjua, Maiduguri and Jere, Kumbotso and Sumaila, Wamoko or Tambuwal in Nigeria, we are especially interested in hearing from you. That does not mean we're not interested if you're from somewhere else. And for Uganda, if you work in Kasese, Mubende, and Wakiso, I hope that you are proud to hear your district or your LGA's name being said today, and that will make you even more eager to contribute. I also can't believe that we're also at the top of the hour. We're going to extend this session by another 29 minutes now. I want to also salute and honor the quality of the contributions that we're seeing in the chat and in the Q&A. We'll be asking the guides on the side after a third case that we're going to present and discuss. We'll then be asking the guides on the side for reflections, and also turning to every practitioner in the room to share something that they have learned, something that they would like an experience, something they have actually done that they believe would be useful to this discussion. So back to you now, Charlotte, as I queue up the third case. Again, these cases were contributed by the individuals that you heard, and many hundreds of others, because you wanted to, you chose to contribute to this process. That is a very important aspect of what we're doing here today. So the third case is from Agaji Adamu. It's also from Nigeria, and this is about integration using missed opportunities. If it is another case, Charlotte, I will of course correct and follow your instructions.
Yeah, so please, can you go to case study 7, since we have moved from integration to microplanning?
Yes.
So we have a series of case studies. So we'll be looking at Aminu Yahaya, that's working at the local government area level in Sokoto State, Nigeria. So the problem here is that past strategies were ineffective in helping them to locate and vaccinate zero-dose children in their region. They had to tailor interventions that could specifically address local challenges. One of such interventions they called Project Radiance, which consists of carrying out in-depth microplanning with communities. Through a routine immunization committee formed with communities, they were able to map out remote settlements, identify key barriers to accessing routine immunization services, and compile a list of zero-dose children and missed communities. all the information gathered was then used to develop a plan which is implemented using what they call the every opportunity strategy, which consists of using traditional birth attendants and traditional babas to identify children, getting information from them on planned naming ceremonies in communities. They then use this information to organize outreach sessions around these ceremonies. So Aminu Yaya is also here with us. Warm welcome to you, Aminu. His mic is already muted. I would like to turn to you, Aminu. Please, can you go ahead, introduce yourself, and I have a few questions for you.
Okay. Good afternoon, good morning, good evening. I'm Aminu Yaya from Sokoto State, Nigeria, as highlighted by Charlotte. And I'm happy to be here part of this subject. As I'm working from State Farm Healthcare Development Agency as an Nigerian officer, working to see how zero-dose children have been reached. And as she stated, our story is also in line with the Microplanning orientation to reach the zero-dose children. Thank you. And over.
Thank you so much, Aminu. Since our session is being interpreted, I would like to invite you to speak a little bit more slowly so that the interpreter in the French language will be able to follow. So my first question, is there anything you would like to add about this approach, that is the project Radiance and the every opportunity strategy that you implemented?
Yeah, the project Radiance and using every other opportunity to get children is a very unique idea, and is a very sound and promising actually strategy. So what I'm going to add up there is, if this is taken up and utilized by other colleagues in other agencies in other countries, it's a promising one. One, it's service user friendly. It's easy for facility to catch up and do it in an easy way, and it costs less and is actually sustainable. So this I want to add. They are very costless and sustainable because it's a community-driven initiative, allowing the community as it is to work on their own and provide a solution to the problem they have. So that's what I want to add up to that. I hope it answers the question. Thank you.
Aminu, I just want to find out from you, is it implemented in all the local government areas of the states, and how many are they?
No. Specifically, is one LGA where this has come up from the facility. Actually, it's not only LGS actually.
Okay. Yeah. And what are your main challenges with implementing this community-based strategy?
Most of the settlement we have issues of how to reach settlement and security. Most importantly, you have to be very careful where you go and where you see people. So you have to start looking which settlement you have to go. For example, you have to make them in badges, because the project is not money oriented. It's just a local one. People come together at the facility to see how they can solve their problem. So that's how we did it. So actually, we look around how best can we implement it and how best it is useful to get it done. As I mentioned earlier, it is sustainable and user friendly. Thank you.
Okay, and what lessons have you learned so far, including any contextual considerations that you have learned in while implementing this strategy?
Yeah, we learn you have to work with the community structure and community leadership, because when you work with them, actually it will help you to work through not on the traditional macro plan where it has been done at the facility level with the LGA staff, with everybody, then come up with fix and outreach session and allow it to go. But when it is done with the community participation, I tell you, allow them to drive the session, allow them to drive the focus, and you guide them, you are going to get the result, because they believe immunization to their own end is not a privilege but a right to get to donor. So if you involve them, you are going to address so many challenges. One, communication gap. Two, addressing so many issues of missed children, caregiver consent, all other issues arising from political, from personal differences, from religious misconceptions, and so many things. So that is how we're able to make sure that, yes, we get it done. Thank you. I'm leaving people, sorry. I'm speaking very fast.
Thank you so much, Aminu Yahaya, for answering my questions. One last question that I have for you before turning towards the guides on this. Earlier on, Dr. Francois Gas was talking about understanding the of the amplitude of the problem. So before you started implementing Project Radiance in one of the local government areas in your state, what was the zero dose situation, and what is it? What is the situation today? So what?
The situation for the first few months or months ago, it was actually not a welcome development, because so many children were missed. And we understand that yes, we need to work to bring those children to the facility. You see so many deliveries at the NNC side, and no child was being vaccinated from those deliveries. So you say, okay, can we research and reach those people? Can we actually make sure that yes, these children are being reached? Because our problem is reaching a large number of zero dose. So by doing this project and the intervention we provided, actually we have seen results, because we have seen an increase of 10% of children, zero dose children, coming to facility on their own. Unlike before, we have to be scouting them there, because we learned that doing that is the best thing to do. That is why we have additional 10% coming now. And before you see 2-3 children, now maybe 5 to 6, 7 children are coming for the first time to get their zero dose vaccination. So that's what we actually achieved. Thank you.
Thank you so much, Aminu Yahaya. Earlier on, we're not able to listen to Jenny. So Jenny, I'd like to turn towards you while I'm inviting our peers and colleagues in the room. Use the chat function to type in your comments around this experience that you have listened to, and the Q&A to ask your question. So Jenny, you have listened to Aminu Yahaya's story. What are your comments or follow-up questions for Aminu Yahaya?
Thanks, Charlotte, and thank you, Aminu. I think what you presented here is the gold standard in microplanning, because often you have a plan and you want to stick to your plan because that's the plan. But what you showed us is that when you saw your plan was not working, you tried to figure out, how do I revise my plan so that I'm actually looking at the problem at hand right now? We know that context change, the scenarios change, but often plans stay rigid and they don't get revised. So I wanted to ask you a little bit about that replanning process. What was it? You said that your past plans didn't work well. You saw that you were not being able to vaccinate large numbers of zero dose. What allowed you to change and reorient your microplan from what you said was a traditional approach to becoming much more community-centered and community-oriented? And how, when you did that, you saw that the community ideas were much better and helped to solve some of the biggest challenges. Can you talk about that replanning process a little bit more? Thank you.
Okay, thank you, John, and thank you so much for the usually before it was, I believe I can do the macro planning at my level, outline, get the list of the line list of the catchment area settlement, and directly do it with the few ones, maybe few to 3 people to get it done. But the realization, we understand that doing that doesn't pay much, because number one, community are not involved in this macro planning. They have not participated fully, and they are not aware. So that is the gap and the issue that make us, okay, can we now say, okay, let's involve them fully, the community leadership, the community influencers, and all the stakeholders in the community, to come up and let's work together and do that planning. We now form a committee. That committee is a macro planning committee which work thoroughly to understand the settlement, the number of zeros affected, and what strategy are we implementing. Now we get them to get the committee to be aware. You see, the chief imams in the mosques were doing their sermons on Friday, preaching to tell people immunization is coming. This is what is happening in the facility. Please, people should go. Then the town announcers are doing the announcement already. It's in the facility level activity in the RI, but still it's not high, it's low. And also, we believe that other influences like traditional barbers, traditional bath attendants, and other community influences are very essential in getting to people to let them know what is there. Unlike before, the information was very scanty to them in that area, and we believe that the usual business can go, we can do the macro, but when we involve the community fully and we give them the steering driving seat to drive the process, that is how we got the changes, because it tells us the gap in communication is there, the gap of getting people informed is there, and all other issues we have like caregiver consent. The committee are aware, tell the different people, let them go, so that family will go, because that issue is also there, and all other differences that are there, we address it. And the communities that we are not reaching and the people are reaching are easily reached by this redesigning and replanning. Thank you. I hope it answers the question. Thank you.
Thank you very much, Aminu Yahaya, and thank you so much, Jenny. So, Reda, I think we can listen to one last person share from Uganda before we open the floor to the other participants in the room. So
That's right. I can barely believe it. It feels like we've just started the discussion, but we know and we respect the fact that you are busy professionals. Many of you have to go back to your duties, and we understand that, which is why we keep these events short. But we hope that if this leaves you thirsting for more, wanting to learn more, wanting to know more, that you'll pay attention to the next emails you receive from the Gavi Zero-Dose Learning Hub and the next opportunities to continue building on this initial intense moment where we're sharing experiences and so many people sharing in the chat. And we again really appreciate it. And so we have 15 minutes left. We'll now go to, I believe, Edwin Musa, who is from one of the districts in Uganda, Kasese district, where the Gavi Country Learning Hub for Uganda is undertaking specific activities. We're going to hear from Edwin Mbusa. Over to you, Charlotte, to introduce the case.
So his case study is focusing on Edwin Mbusa, as you said, is from a health facility in Kasese district, and his challenge has been to devise methods for better identifying underserved villages and tailoring immunization strategies to their specific needs instead of using a generalized approach. So to them, they introduced a microplan template that made them to ensure that no children were overlooked by engaging village health teams who registered children and checked vaccination statuses through house-to-house visits. They then plan outreach posts in remote areas based on this data. They now regularly update their microplan. So I just want to ask Edwin, please just quickly reintroduce yourself and specify how many more children have you been able to reach now than before because of this intervention? And how do you know? How do you know? What data do you use to measure that? Over to you, Edwin.
Thank you so much.
Edwin, we can barely hear you. Can you speak more loudly or closer to your device?
Okay, thank you so much. This is Musa.
Edwin, I'm sorry, but there's a problem with your microphone. You need to really shout into your microphone or increase your volume, please. Much better. Thank you.
Yes, working from a health facility. And so, basing on the strategies that we have laid to reduce the number of children that are not immunized, we have been able to improve, like DPT1 coverage has improved from 80% to 90%. And this one we have been able to identify through checking, making regular evaluations, especially using the data in the child register, the tally sheets. And so we have also established performance graphs basing on the targets, so that at the end of every month, you are able to know the number of children that you have vaccinated, and you'll be able to monitor the performance using the graph that is established.
Yes, Charlotte, you're muted. Charlotte is having connectivity issues due to a power outage. Charlotte, we hear you. Yep. Yes.
Yeah. So I want.
Right. This time
I wanted to find out, lastly, from you, how were you able to add more outreach posts? Did you receive more funding in order to do that?
Yes, through the Gavi funding. Gavi has been
Reda?
funding. Yes, Gavi has been funding integrated health child days programs that are always done in that we always do in April and October. Then that one has helped us Then also UNICEF has helped us to fund some additional outreaches in order to reach some hard to reach areas, because we find out that the funds that are available sometimes do not cater for the number of outreaches that we should reach. So Gavi has been funding us through UNICEF to also reach those hard to reach outreaches. Thank you.
All right, back to you, Charlotte. Charlotte may be having a delay or may not be hearing me at all, in which case I would like to turn to Rita Tuganza, who's the Deputy Director of UNEPI in Uganda. Rita, a warm welcome to you. Charlotte just presented, and then we heard from Edwin Mbusa, who works in Kasese District on microplanning and then revising plans with community involvement. I don't know how much of this case you were able to hear, but we'd love to hear from you. And just starting with, what is your perspective on this inter-country peer learning exchange taking place today between practitioners from Uganda, Nigeria, and many other countries?
Rita, first of all, apologies for joining late. Unfortunately, I had to stand in for the program manager in another meeting. I'm very excited, and I hope that this will be the first of a series of client interactions inter-country, so that we can learn from our colleagues. We can't operate in a bubble. So it's always beneficial to hear what the experiences from other countries and how they're able to reach their immunized and zero-dose children. So for my colleague from Kasese, I was very excited to hear about the use of data. I think it's the foundation against which programs can improve performance. If you don't know how you're performing, if you don't know how many children you're missing, then you're not likely to actually actively look for them. So for me, that was a very, very key point from my colleague in Kasese, and I want to applaud them for using their data. Rita, over to you.
Thank you very much. Rita, you are one of our guides on the side for today. I believe an electricity outage has prevented Charlotte and Boo from continuing with this session. So, and we are now with 9 minutes remaining in the session. So what I'd like to do now is, first of all, to thank Edwin Mbusa and to open up. There are many hands raised. I'm going to lower all of the attendees' hands, and I would ask you to raise your hand if and only if you have something very specific that you have actually done or carried out that could be useful to the to Edwin Mbusa and the implementation challenges and data challenges that that he is facing. So let's go to let's see. So remember, before raising your hand, to think through that. Would love to hear from Hilary Okello. Hilary Okello. Oh,
thank you very much, Reda, and everybody.
And do introduce yourself, Hilary, first.
Yeah, I'm Hilary Okello. I'm a TGLM, the Geneva Learning Foundation ambassador. I work in Lira City. I work at both the facility level and at the district level. So I tend to do both. I just want to add on what my colleague has just stated with what happened actually with us. You see, after learning from the first ZDLH session, the other one of Mali and Bangladesh, I realized that identification is the most critical thing which needs to be done. And after that, I screened, I realized that all the zero dose we were only getting from the campaign, there was no clear data tool which would capture zero dose. So when I took this one up, I realized that the first thing is to make people know that there is zero dose which exists and can be got. So I call all the EPI focal person, the in charges, the parish supervisors, and the head of vaccination. we sat for a meeting. In that meeting, we reviewed our microplan. From the microplan, we realized the gap which we have. That so far, this is what we have vaccinated. The remaining is this. How can we now reach all those other ones? Then from there is when we realized, the team realized that me in my village, I'm left with this number. In my village, I'm left with this number. So they went in full swing, mobilizing and even reaching house to house. And that is how we managed to succeed. And as I talk now, we have achieved our coverage up to almost 105% of DPT3 from 87, which was terrible. So I see that it works. If we continue like this, we will reach all the zero dose, we will reach all the unvaccinated, the unimmunized. Then also the emphasis on daily routine immunization at facility level. Much as the outreach is also ongoing, but there must be daily vaccination. Then also never leave a mother who has delivered within a facility to go without receiving the first dose of BCG. Thank you very much. Over back to you, Reda.
Thank you, Hilary. Just one last question for you. Can you remind us which district you work in Uganda? Where's your primary focus?
I'm in Lira City.
All right, thank you. Okay, we have many hands raised and 5 minutes remaining. So I would like to turn to one more person, and then we'll wrap up by turning to Heidi Reynolds from Gavi, who's been listening and learning as a global partner for the country zero dose practitioners that we've been listening to in this session. We'll ask her for her closing thoughts, but it'd be great to hear at least one other person that we have not heard before responding to Edwin Mbusa's challenges. So let's go to Mustafa Aliyu, inviting you to talk. We'll see who is first on the microphone button. Paul Kunsa. Perhaps let's see one more person.
Thank you very much. My name is Paul Kunsa. I'm the immunization consultant working with Kasese District. I'm glad for Edwin's submissions. I am glad to add that at least all the villages, 143,900 people. So these facilities have been mapped, which are 867, so that no village is overlapped with.
All right, Paul, I'm so very sorry. Your line is breaking, unfortunately, much to our dismay, much to everyone's dismay. I would suggest, Paul, if you could type your messages in the chat. As you can see, there's a very active dialogue, as well as many questions piling up. With 3 minutes remaining, I would like to turn to Heidi Reynolds from Gavi. She is leading this Zero-Dose Learning Hub project from Gavi, the Vaccine Alliance. She's been listening and learning with all of us today, listening to experiences shared by practitioners. Heidi, what are you taking away from this discussion, the second time that two countries, practitioners from two countries have met to share their experiences?
Thank you, Reda. Indeed, I have been listening and learning. I really appreciate all the people who have participated and contributed. And it is indeed quite a rich source of information that comes through, not just during this time, but I know all the information that you have submitted ahead of time. So I want to just assure you that this information does get sort of reviewed and synthesized, and we take this information to really understand how implementation is working at your front lines in order to identify and reach those children. And that information gets also synthesized and put in and packaged in ways that we can share with other people. For example, this country managers at Gavi who want to know how implementation is going or what the challenges are. And that information gets shared across to other countries as well. I was really happy today to hear about approaches, integrated approaches with other health areas, and how some of you are using other contacts in other and other opportunities, such as if somebody comes into a new facility or a pregnant woman, in order to identify people who may need immunization services. I also really appreciated the discussion around the use of planning tools such as the microplans, and really the explicit effort to identify kids in communities that may not have ever been reached, and then using those tools and adapting them to make sure that you're actually reaching those children. I always appreciate hearing about your data collection and how the data are being used to make decisions. I think that's a really important piece that we don't have enough visibility on. And again, one of the comments from the guys on the side I thought was really important in terms of articulating what is the magnitude of the problem that you're trying to address with the strategies that you're implementing. That can be a really powerful message to understand how that is actually making an overall impact, not just at the district level, but up to the national and global levels in reducing the level of zero-dose children. I will stop there and thank you again for your participation.
Thank you very much, Heidi Reynolds from the Gavi Secretariat in Geneva, Switzerland. All right, we are at time at the 30-minute mark with hopefully Swiss punctuality. Of course, yes, the presentation can be shared, James Onoja. It feels like we're just kicking off a discussion, but it also feels like a lot more thought went into this ZDLH inter-country peer learning exchange, as evidenced by the quality of the comments and experiences shared, the level of preparedness of the speakers. Very impressive leap since the first inter-country peer learning exchange that was held just on the 31st of May. So really we look forward to, and we're now going to say a little bit about what is coming next. First of all, just to clarify very quickly what we will be certifying. So if you have contributed your zero-dose experience ahead of this ZDLH-X, you'll be receiving an official letter of commendation, as well as if you have contributed what you learned during or since or after this event. We'll be giving you a 2-week period during which we'll be asking you questions, and that's a second opportunity really to share what you learned, and that will also be recognized by us as we believe this is where significant learning happens. Many great comments in the chat, as you can see, and then the next time we will convene as a Zero-Dose Learning Hub X exchange will be for an Insights Live session. That'll be on the 4th of October is what we were planning. You'll be, of course, receiving the exact dates and other information. And what we do at Insights Live is we ask you a very simple question. You spent precious time listening and learning today. What have you done with what you learned? And that is what we'll be asking you just a little bit over 2 weeks from now. Last but not least, you have until the 1st of October now to share what you learned during this session and to tell us also how you intend to apply it. That's it for this second Zero-Dose Learning Hub Inter-Country Peer Learning Exchange. Again, want to acknowledge the 2,203 or more immunization professionals who registered. Most of you directly involved in zero-dose work, most of you working at the sub-national levels, and many of you from the districts and LGAs where the Gavi's Zero-Dose Learning Hub country partners will be undertaking research and other activities to support zero-dose practitioners. That's it for today. I am so sorry, Charlotte, I believe, did not make it back into this session. That happens. Thank you. Oh, you're back. Okay. That is so great. All right, let's have a round of applause.
Yeah.
All right, Charlotte, final thoughts on what?
So I just...
Yep.
Yeah, brother, I just wanted to thank all of the contributors from Nigeria, from Uganda, but from all of the other countries. countries that prepared and joined this event today to share the work that they have been doing in their context to identify and reach zero-dose children and communities under the framework of integration and microplanning. I also want to thank our guides on the side, Boma Otobo, Dr. Rita Atugonza, Dr. Francois Gaz, and Jenny Sequeira, and also our colleagues from JSI, from Gavi, and from the country learning hubs in Nigeria and Uganda, as well as all the TGLF ambassadors from our 4 country learning hub countries. It was a real pleasure, as always, to be part of this great event.
Thank you very much indeed, Charlotte. Really want to recognize the collaboration and partnership of the Uganda Country Learning Hub and the Nigeria Country Learning Hub, AFINET, PATH, IDRC, and of course the Ministries of Health of both countries. Thank you very much indeed. And still an amazing 370 people still in the room. Wow. All right, look for your email for the follow-up. Thank you. Merci. Dumbo Roland, Janinga, Iwosu Grace, Christopher Dradiku, Victor Biamukma, and Dayo Iwat, Bello Ibrahim, Martin Musa, Michael Jones. It's hard to keep up. Umar Ifino. It feels like nobody wants to leave. On dirait que personne ne veut partir.